Yeah.
You're live now.
Oh gosh, okay, I'll not swear. So thank you to John, and obviously LIVErNORTH, I every now and then get invited to come and talk to you. So as John mentioned, I'm obviously a hepatologist. Autoimmune liver disease is my specialist interest, and obviously some of you in the room are on the receiving end of some of my expertise. That's it. So I thought I'd talk to you about autoimmune liver disease today, and just a few kind of different aspects of things, some of which is very close to my heart and some of which people in the room have been part of. By all means, just interrupt, ask questions, I don't mind at all, so you can interrupt as much as you want. Now, so EALD, which stands for Environmental Factors in the Etiology of Autoimmune Liver Disease, or EALD, depending on. So that's my PhD, and many of the people in the room are participants in EALD. You know who you are, and many of you will have filled in a 27-page questionnaire about whether you've used roll-on deodorant and various other things. So thank you to you, because I got my PhD on Friday. But it is thanks to people in the room, because actually they took part. And actually what I was looking at in my PhD is that essentially we think there's kind of a genetic bit to autoimmune liver disease, but it's only a bit of the story. And actually increasingly we think there's probably things in the environment that may explain why somebody goes from having some genetics to being tipped into having disease. And actually my PhD has suggested that there are clusters of patients. So there are areas in this region where there are more patients than one would expect with autoimmune liver disease, and whether actually there may be things in the environment that we might be able to start to kind of pull apart and try and understand. Because a lot of people who come to the clinic will say, why did this happen to me? Like, why have I got this? And I have to say, I don't know is the honest answer, but we're trying to kind of understand that, and EALD is kind of the study that we've been doing. So, as I say, it's shown some stuff, and this is just a bit of background about it. So, as I say, there definitely is a genetic bit, and some doctors are very keen on genetics. And even now, even the people who are keen on genetics would say that autoimmune liver disease is probably only somewhere between 10 and 20% is genes, and the rest of it we don't really know what causes it. And this, I don't want to be videoed, but actually I can put this. Hang on. Oh yes, you see here, so this is the northeast of England, as many of you will recognise. And these pictures are taken from old studies. Many of you will remember Ollie James, probably, and Jane Metcalf and Martin Prince, all of whom have been part of the liver unit here. And they did some studies looking at some of the population in the north of England years ago now, and again showed that there were clusters, there were groups of patients, more than one would expect, in PBC, so primary biliary cholangitis, the commonest of the autoimmune liver diseases. Now, there are lots of people in my clinic with PBC, but there are also autoimmune hepatitis, the second commonest, and then primary sclerosing cholangitis, PSC, so that's the rarest of the three. And as I say, there are these clusters, so that multicoloured picture is also the northeast of England, and the red bits have more patients than one would expect with PBC. And actually, I'll go on to tell you that I think that's true. So disease clustering, high numbers of patients with PBC, but this has never been done before in autoimmune hepatitis or PSC. And, what's happening here today?
Process.
I mean, the computer system is human is... Sunderland referrals, we'll get rid of that before we...
Oh, well.
That's a different story altogether. So PBC obviously is only one of the diseases, and I'm kind of obsessed with all three. So I wanted to have a look and see is the disease clustering, and is it in all three diseases? So, as I say, we wanted to look and see, are there groups of patients in kind of with disease that are more than one would expect by chance? And is it the same? Is PBC, autoimmune hepatitis and PSC, are they all the same? Because of course, for those of you in the room who've got any one of those diseases, you will know that they are different diseases, you get different treatments. And then to say, well actually, can we begin to have a look and see if there are things in the environment that may be related to disease? So the study was, now you all know where we live, so that's fine. But the study is northeast of England and then across over to North Cumbria. So the old studies by Ollie James and people only looked at the northeast, so looked at Tyneside essentially, and kind of a bit further down. But this study went right over to the west side because we cover, the autoimmune clinic covers the kind of whole region. And there's about 3 million people in this area. And people don't tend to move in and out of the northeast or North Cumbria very much, and actually it makes it quite a good place to do this type of study, because what you want to know is that if there's something in the environment, are those people being exposed to it for a long time? And as you know, this bit of the country, so some of it's very rural, you know, the Lake District, and then some of it, obviously Newcastle particularly, Stockton, Durham, very urban. So, the patients, the most important thing. So, I've spent more time than I would like to remember trogging through lots and lots and lots and lots and lots of blood results and lots of antibody results and lots of x-ray tests in every hospital in the region. So there are 13 hospitals in this region. And I tried to find every patient we have with autoimmune hepatitis, PBC or PSC. It took ages. And actually, what I found in the end, long story short, for the purposes of the study, we had just over 2,000 PBC patients, nearly 1,000 autoimmune hepatitis patients, and nearly 500 PSC patients. And that's split roughly because PBC is twice as common as autoimmune hepatitis, which is twice as common as PSC. So I've kind of found all of these people, and then I wanted to have a look at those people and say, well, actually, do they seem to kind of live closer together than one might expect? So I like a picture. If you come to my clinic, you quite often get a slightly poor quality diagram of the bile duct. So this is our study region, and you can see these are, each map denotes different groups of patients. So the blue dots are patients with PBC, green dots are autoimmune hepatitis, and red dots, I'm struggling with my colours, red is PSC. So they're kind of all over the region. And then we kind of wanted to think about, so this is all about the environment, and actually, are there things in our environment that may be related to disease? And if there's lots and lots, there's a certain amount of kind of investigation into this previously. So the old study by Ollie and team suggested that there was more people with PBC in urban areas. And then there's also, you might think, well, actually, is the pollution in the area that's causing this? So we looked at various things. So coal mining, obviously we have a massive heritage of coal mining, particularly over this side. Lead mines, quarrying. We also looked at heavy metals. So there's been quite a lot of, there's kind of various flurries in the press about cadmium and other heavy metals that may be causing problems. And then there's some, generally speaking, in places that are less kind of affluent, I suppose in poorer places, you often get more disease. So you see higher cancer rates in poorer places. You see people, more kind of heart disease and things in poorer places. And ill health often goes together with less well-off areas. So we wanted to look at that as well, so socio-economic. This is our study area again, so this is the northeast of England and North Cumbria, just divided up by postcodes essentially, because that's what we kind of grouped people into. And now these are my favourite pictures. So this is just to show you that, yeah, there are areas of high risk for these diseases. And what this means is difficult to know, but essentially the bright pink bits are areas of high risk. So PBC on the left-hand side, PSC in the middle, and autoimmune hepatitis on the right. And you can see that, as Ollie and team found, so this is kind of Tyneside and just above Tyneside, so up kind of Blythe way. So very urban areas. There were higher groups, a higher number of PBC patients than one might expect. And then PSC, more over the far side actually, so over towards kind of Carlisle, Cumbria. And then autoimmune hepatitis, kind of dotted about. But again, there were definitely areas that, so this is not just more people live in these areas. So this is all controlled for the number of people, if you see what I mean. So it's not just there are more people living there, so there are more people with disease. And you can quite clearly see from those maps that there are areas where we have more patients. Does that?
Yeah, can I ask you the left-hand map where PBC, is that Carlisle, a little red spot?
No, Carlisle's further down.
All right. that's not a central population then?
No, so it's definitely not just how lots of people live where, it's not just where lots of people live. But the PBC stuff definitely maps onto what Ollie and people found.
Can I just ask a question? You know when you had the females, you had so many females, right?
Yeah.
What about men?
Oh, so then, yes, I see what you mean. So then I've just kind of put females and not like the rest of them are men, if you see what I mean.
Oh.
So yeah, so PBC is traditionally 90% female, which is what ours was, so the rest of 10% are men. And you see, so they're what you would expect. So 90% females in PBC, 80% in autoimmune hepatitis, and then PSC is the opposite. So about it's much more common in men. So about 70% of patients with PSC in men. So, but it is it is one of my obsessions. And again, if you come to my clinic, you'll get me wittering on about understanding what causes disease. Because actually, if we can find out what causes it, then potentially that's the kind of.
Jess, can I just check in relation to, is it per head of population that those graphical colours are created? Not just the numbers, because I mean the population over in Cumbria will be a lot less.
Yeah, no, absolutely.
So is it per head of population?
Yes, so if you can map it by just absolute numbers, as you say, and all you find is that more people live in Newcastle and more people have PBC in Newcastle, which is not rocket science because Newcastle's a really heavily populated place. But yeah, they're controlled per population density, essentially. So it do seem to be different in the three different groups of patients. And certainly in my clinic, so Mark Hudson, who many of you will know, has always said that he feels like PSC, there's lots of patients from Cumbria and Carlisle with PSC, and he's right. So I think it is really interesting. I think it's potentially really important. And as I say, there are quite a lot of people in the room who are part of EALD. So my thanks goes to them.
Which one is that? PBC?
It's
Carlisle?
PSC.
Is that
The middle one.
that one, is it?
Yeah.
That's weird, that lady.
It is, and it's very so. And of course, we're not saying that. So we're not saying what causes disease. I mean, we're no. If we're honest, we don't know what causes disease. What we're trying to do is pick apart if we could find something that was a risk factor for disease, or if we can understand disease better. Because actually, all three are immune system problems. But why do I don't. Theoretically, why do I have PBC and John has autoimmune hepatitis and Joan has PSC? None of those things are true. No, but just for the sake of, I don't want to highlight people in the audience who do have this. But you know, for the sake of discussion, why do we all have an immune system disease? But why does one get one and one get another? And is there something that we can do to? Yeah, exactly. And undoubtedly, with autoimmune hepatitis, particularly, there are some. Rarely, but there are some medications, for example, that trigger autoimmune hepatitis. So that's trying to understand that better, because actually I don't want to just be able to give you treatment for it. What I'd really like to do is understand why it happens, and then we can stop it happening. That's the kind of the golden egg, as they say. So yes, that's the kind of. There's lots and lots. The study is the 27-page questionnaire that people have filled in will not go to waste. That's my next mission, is to start looking at that data. But yeah, so that's kind of the headline of my PhD. So I just wanted to.
Is there any evidence that suggests it runs in families? In those areas. In Cumbria.
So I haven't. So that's a good question. So I haven't. I could look at that. I haven't specifically looked at genetics in this study, but if you look more generally, there was definitely. You are higher risk. It's not genetic diseases. They're not passed from one person to another, but there is a higher risk in family members. So we don't screen. So people sometimes come and say, "Oh, actually, should my family be screened?" We don't routinely screen families because it's not like it's not cystic fibrosis, for example, where a gene causes that disease. It's not like that. But there is a higher risk, and some people will tell you, "Well, actually, my mum's got thyroid problems, and my dad's got." Pernicious anemia, my sister's got rheumatoid. So you often find families have quite an immune system kind of overexcitement. They're often there is definitely genetics.
Why is the red colour and the green much bigger than the blue and the other one? Size
of square wise? Oh, you mean the scales?
Yeah, the length of the...
It's just
range?
so so you can slice it any way you want. I sliced it so that you can see. I've set the what's the word I'm looking for? I've set the scale so that the picture is very clear. You can do your cuts anywhere. So I could have made it so each of those bits was a different colour. It's just a graphical representation. Sorry, you were saying?
Did you look at the age of the people as well who took part in the survey, see if that was any significance?
So not for this. So I will look at, so we broadly speaking will have more women than men, just because they're much more common in, immune system problems generally are much more common in women, PSC being the exception. But yeah, so we'll look at that when we look at the kind of the dreaded questionnaire. Yeah.
Based upon these results in comprehensive vessel form, can you generalize these results for London area?
So that's a good question as well. So I think part of the no is probably the quick answer to that question. So I think our kind of northeastern North Cumbria is quite distinct in the sense of its kind of mining heritage, for example, and obviously things over on the far side, farming, etc. But they don't map directly. What you're trying to do is understand it's kind of burrow down into understanding the disease, which then would be generalisable. But yes, I would. This isn't kind of Wales or. I want to look at Wales as well because Wales has lots of mining.
So obviously the north east must be like a hotspot, right?
Yeah.
What about down south? Is it more better?
So traditionally, PBC is meant to be high levels of PBC in the northeast and high levels of PBC in South Wales.
Right. Was that because of mining as well?
So that is that. If I haven't got it in here. Dangerous asking me questions where I could talk about this all day. Traditionally, the population and the mining heritage is very similar in South Wales and the northeast of England. Now, to be fair, part of why, so certainly in this region, you could argue that we have more PBC here because we have a specialist centre and there's more awareness and people test for it more. So do you just find more patients? Right. So you could argue that. And South Wales, there has been a specific study done in South Wales looking for patients with PBC, so you may just find more. And nobody's ever done it in autoimmune hepatitis or PSC.
Right.
And it's just never been done.
So what about sort of like Nottingham way? Because that's miners all around there, isn't it?
So no one's ever looked.
No, nobody's ever looked. So really what they want to do is do a whole national thing.
Yeah.
Really.
So UK PBC, so there's the UK kind of national studies, so there's UK PBC, UK AIH, which I run, UK PBC, which Dave Jones, who most of you know. So they're the national studies. So the problem with that, so they're brilliant because I run one of them, but they don't include everybody, so you don't have the same kind of level of coverage. So UK AIH we've now got about 2,000 patients, but they're kind of dotted all over the country, and it depends, if, for example, King's Hospital in London take part, so we've got lots of people in London who are part of it, but if your hospital in another city isn't taking part, then we won't have patients from there. So you don't get that same kind of comprehensive week, so you can't look at it quite so well. Anyone else want to?
Nothing to do with cellophane radioactivity.
I wondered if somebody would ask me that. So that's an obvious, certainly the patients who come from that kind of near there do wonder about that. I don't have any evidence that Sellafield causes disease. I think people do worry about that in terms of, but there doesn't seem to be, it doesn't seem to group around Sellafield actually.
Talk about long term in the system and mining, etc. We've got a cluster on the Thames side, and we had two massive incinerators, one at North Shields, just on the other side of the Thames tunnel, and one within 200 metres of where I live. There was 10 houses on the stretch of the street. Every single one was lost a family member to either cancer or PBC.
Yeah.
It took them a long time to accept the fact that they were burning too low temperature.
No, I think
they were burning general waste at about 1100 degrees instead of 1300 degrees.
You make a very valid. So actually, if you look at, so one of the things I looked at was landfill sites, which are not quite the same, but based on the fact that actually there's some American data that would suggest that waste tips are related to not a cause, but there is a kind of relationship to high levels of disease. And yeah, I mean, I suppose you would have to question whether any source of pollution. Of course, incinerators will give you air pollution, which we all breathe in.
But I would get up in the morning to go to work, and depending on which way the wind is blowing, my car would be covered in
exactly.
dust.
And it does make you wonder, doesn't it? And what we're chuntering.
Side conversation.
It's all right. I'm used to it from him. Don't worry. Not you. What? You causing trouble?
No.
I'm used to it. It's fine. Does anyone else want to ask me any questions? Yeah.
It's interesting when you say you're looking at the hotspots of South Wales and the North East where coal mining, etc. However, when you gave the figures for PBC, it was nearly 90% women who are not in.
So no, that's a really interesting point. So if you think about the asbestos mesothelioma, which obviously is a very well recognised relationship, and actually there were lots of wives of men who worked with asbestos because they washed the clothes of their husbands. So, because at first glance you would think exactly that, but actually mesothelioma doesn't just affect the men who worked with asbestos. And the other thing about the female thing, so females are much more at risk of immune system problems generally. But yes, you're right. So I don't think it's just as simple as it's not just that a man went down a mine and got PBC. Yeah, you're absolutely right. But there's certainly, if you look at other things like asbestos and people washing clothes, etc.
Because the dust in it.
Potentially.
Get the clothes home and then you shake
exactly, and that's what happened with asbestos. Yeah.
And the dust comes off there, doesn't it?
And I think it's really important to say we're not trying to say that any one thing causes disease. What we're trying to do is kind of understand it better, and then see if we can. Because if we can understand triggers for disease better, I think we could.
What about chemicals? You know, see if somebody's using chemicals and stuff.
Yeah.
You get it on the hands and doing stuff like that.
I think all of those
that
things.
Be absorbed.
Yeah. Well, you can. If you absorb stuff through your skin, then yes, you can kind of process that through the whole body. So in some ways, I've probably generated more questions than I've answered, but I think it's a step in the right direction. Am I all right?
Yeah, move on. We're fine.
So, so that's my kind of a bit of stuff from my PhD, partly because I wanted to share it with you because a lot of you have been part of it. And then a bit of stuff about PBC, so primary biliary cholangitis. So we've said it's the commonest of the three diseases. I say common, it only affects 35 per 100,000 population. It's just that I look after a lot of people with PBC. So just to kind of, I mean, John and LIVErNORTH more broadly have been a key part in this, but PBC used to be called primary biliary cirrhosis. It was a really poor name for some people, because actually a lot of people with PBC don't have cirrhosis. And any of you who've got a liver disease and have tried to get any form of insurance will know that it is a complete nightmare. And actually telling an insurance company you've got cirrhosis is a surefire way to put your premiums up. So actually about probably two years ago, is it that long? Probably. The name has changed. Yeah. So it's now primary biliary cholangitis, which is a much more accurate description. And I spend quite a lot of my time writing letters for people saying this person does not have cirrhosis or this person does have liver disease, but actually they should be allowed to go on holiday. So just to say we have changed the name because it was inaccurate. So as I say, it's technically a rare disease. So you have to be a rare disease, you have to have under 50 people per 100,000 population. We've said you made the comments about gender. So 90% of patients with PBC are female. And traditionally it was felt to be a disease of people who were a little bit more mature. You have to pick your descriptions about how you say these things. So the average age of diagnosis is 65 years. That is probably changing with time, certainly in the time I've been looking after the clinic. We are seeing more younger people, I would say. And I've already said that actually autoimmune diseases tend to go together, so some of you in the room will have one autoimmune disease and potentially another one. Your thyroid might also be a problem, and also in families we also see kind of an autoimmune picture, if you like. PBC, out of the 3 autoimmune liver diseases, is by far the easiest to diagnose. So you have abnormal liver blood tests, and then you have these antibodies. So the immune system is designed to protect you from the outside world, and in some people, for an unknown reason, it gets overexcited and starts trying to attack bits of you. So all of these immune system liver diseases are the immune system essentially being a bit overexcited. So anti-mitochondrial antibodies are just proteins that the immune system gives out, and they're very, very specific to PBC. And older people in the room will know that historically we used to do a liver biopsy on pretty much everybody with PBC, and a lot of patients got lots of liver biopsies. That's very much gone out. Broadly speaking, we biopsy relatively little now for PBC, and because the blood tests are so accurate. There are a few situations in which we do a biopsy, but generally speaking, the blood test will give us the answer. And actually, a lot of patients will say, it's not my liver necessarily that I'm particularly worried about, it's the fact that I feel absolutely awful. And there are 2 big problems, 3 big problems, I would say, and people might want to comment. So itch. So a lot of patients with PBC have horrible itch. I have lots of drugs for it, which I give out like they're going out of fashion. But some people have really difficult itch if we need to treat. Fatigue, so an overwhelming tiredness, and obviously I can't comment from a personal point of view, but patients will often say that it's not the kind of tired that you feel at the end of a busy day. I think it's a kind of overwhelming fatigue. And then the third thing is what I think people would themselves describe as kind of brain fog, feeling like it's just kind of not all kind of linking together quite kind of as quickly as they want. So what we would call cognitive symptoms, but patients describe as feeling like they have brain fog. However, although lots of people have quite a lot of symptoms, there are a good number of people who just go for their routine health check and get their blood pressure done. Somebody does a blood test, and then they've got abnormal blood tests, and then they get sent to me, and then I have to say, well, actually, you've got an immune system liver disease that you never knew you had, was doing you no harm. And that's a massive thing for people. So they go from having a normal blood pressure to coming to see me to being told they've got PBC. So there's a whole spectrum of people, some of whom really have very little effect from their PBC, and some of whom have huge impact on their quality of life. So I would say, so if you come to my clinic, I'm trying to achieve, broadly speaking, 2 things. I want to reduce any risk to life. I want to reduce your need for needing a liver transplant, and I want to make you feel better, and I want to give you a good quality of life. So I would say, overall, what I'm trying to do is give people a normal quantity and quality of life. And those 2 things, I think a lot of patients would say are equally important to them. And in fact, some people would say, actually, I don't really mind if you can't cure my disease, but I just want you to make me feel better. So, fine. So treatment. So for PBC, we use urso, ursodeoxycholic acid, urso, I would say. It's a very safe drug. The vast majority of people with PBC will be on urso. It's very safe. Some people do get side effects, but they're a relatively small proportion. And we're increasingly trying to kind of give people a bit of ownership of their own health. So actually we use liver blood test markers as whether you respond nicely to treatment. And we are trying, so I tend to try and explain to people, if they want to know, but try and explain to people how I'm kind of thinking about whether they're doing well with treatment. And because actually that allows me to tell you what your risk is of running into problem over time. And I think that's what many patients are worried about. Like, actually, am I going to be here in 10 years' time to look after my grandkids? And hopefully we are beginning to be able to give people that information. About 80% of people do brilliantly well with Urso, but there are a small proportion of people who Urso is not enough for them, and I have to think about giving you extra treatment. Now, time seems to be speeding up. About 18 months ago now, we got access to hepatologist acid, which some of you in the room will have heard of. So that's a new treatment which I can use as an add-in therapy for patients who do not have good blood test response to Urso. I've got, how many people have I given it to? 38 to be precise, as of this week, I believe. And so we're just kind of finding our way through it. There's a national, it's a kind of, John mentioned it being a specialist centre. At the moment it's very strictly licensed, so you have to come to Newcastle for me to prescribe it for you. The problem is that it does cause itch in some people. Now we've already said that people with PBC get itch, so it makes, you know, if I give you a drug, it can make your blood test better, but if it makes your itch worse, then that's obviously far from ideal, so giveth and taketh away.
It's working.
No, well, exactly. So it helps some people, but it's not the answer for everybody. And then fibrates. So some of you will have heard of fibrates because they're an anti-cholesterol drug, actually. I'm a massive fan of a fibrate. I think they're really good drugs. And they're not licensed for PBC, so the way the NHS works is you have to, well, you're meant to have licensing for drugs, but actually fibrates, there is quite good evidence that they do good things to people's blood tests in PBC, and I use them a lot in our clinic, and actually we see some really good responses. I've probably got about 150 people on a fibrate, and some people just, well, get normal blood tests, which is fantastic. We kind of alluded to, excuse me. We talked about UK PBC, so this is the national PBC study. So this is kind of information from that. So UK PBC's now got about 8,000 people in it, I believe. And we talked about, you know, I want to make you live longer and not need a transplant, but I also want to make you feel better. And actually, PBC patients, there is a big problem with symptoms and quality of life. And actually what we're seeing, if you look at the whole kind of national group of patients with PBC, that actually often it's the people who present at the younger ages who have very heavy symptoms. So I'm increasingly seeing people in their 30s and 40s, which we didn't really used to. I sound very old, don't I? Professor Jones didn't used to see people in their 30s and 40s. But interestingly, people who are presenting at a younger age often have a lot of itch, for example. So there does seem to be, it's becoming an increasing problem probably. When I mentioned itch, I think anybody who has, so before I ran the clinic, I think it's easy kind of to dismiss itch and think, we're all a bit itchy, aren't we? Now I do a clinic where people come and tell me about their itch, and itch is a terrible, terrible symptom, and it genuinely ruins people's lives. So I'm quite aggressive at managing itch. I think it's, PBC itch is worse at night as well, so actually you can't sleep, you know, it's horrible. So I'll give everybody Questran, which is the horrible sachets. Anyone who's ever taken them will tell you that they're pretty manky, and a lot of people don't like them. They're a good drug, but they don't taste very nice. And then you move on to rifampicin. Rifampicin is a very old-fashioned antibiotic. They used to use it for TB, actually. And it is still used for TB, and that's pretty much it. But rifampicin really works for itch. We don't know why.
You just calm it down, like.
So, I mean, I don't know whether anybody in the room would want to comment, but yeah, so we don't know why it works, but rifampicin, for some people, is a brilliant treatment for it.
It makes your tears orange.
It does. It makes your bodily fluids generally, doesn't it, orange? So you cry. So this is something we sometimes forget to warn people about. They go home and cry. That's the effect I have on people. They go home and cry, and their tears come out orange, and they wee orange, I believe.
And yours spits as well.
Yeah. So all your bodily fluids turn orange. So yes, it is quite useful to warn people about that, because otherwise they get a bit of a surprise. Particularly if they cry in public. But it is a good drug. It has its risks, but it is a good drug. Beyond that, we then start to think about gabapentin. So some people in the room might be on gabapentin for different reasons. So actually it's a painkiller, so it's used classically for kind of nerve pain, so sciatica, for example. But again, it works for itch in some people. And then beyond that, you're kind of moving into this slightly, kind of the the stuff that doesn't really have very much evidence, but works for some people, and that'll do me. I don't really mind whether it has evidence if it works. And right down the bottom, interestingly, light therapy. So, sorry, yes?
You just said pregabalin helps itching. Is that what you said?
So gabapentin does. So pregabalin is just a newer version of gabapentin. There's never been a trial of pregabalin, but they're the same drug group. So yes, I mean, theoretically, if gabapentin works, then pregabalin could work as well, for some people. Yeah, in light therapy, so sunlight's really, so I could prescribe holidays maybe. I could go with them as my personal doctor. But light therapy works beautifully for itch in some people. Just in terms, so classically, palms of hands, soles of feet, worse at night, worse than a hot bath, is what, you know, if you were writing a textbook, somebody would tell you that itch is about. And the interesting thing, iron deficient makes people more itchy, so I always check for iron levels and things because it makes you more itchy. And actually, I was saying that itch can be absolutely destructive for people. So you can still get a transplant for itch. You don't have to have cirrhosis, you don't have to have end-stage liver disease, you can have itch, and we will transplant solely for itch if necessary, because that's how severe that is for people. And it is, I think, probably one of the most, we've done a few of patients I look after, and they literally go to sleep, have a transplant, wake up in the morning, the itch is gone. It's quite remarkable. And they think I'm mad, and they think I'm lying to them, and then they wake up from their transplant, and they're like, oh, it's gone. Okay, yeah, no, it's amazing.
But it has no effect on fatigue.
So that's absolutely true, and I think historically, people thought that a transplant would make them less fatigued, and you're right. There is no evidence that transplant improves fatigue, and as many people will know, fatigue is our biggest enemy in the sense that we have no treatment for it. We did the rituximab trial. So rituximab is a quite hardcore immune suppressant. We take fatigue very seriously. We gave rituximab to people, and sadly it didn't improve things. So, yeah, fatigue at the moment we have no treatment for. It's a work in progress. But yeah, I can treat your itch, but fatigue is very difficult. I'm going to run out of time, John.
No, you're fine.
I'll tell you what, just one word about more. You've beaten me to it. Look, no evidence of benefit with transplant, you see. Yeah. The other thing to say is that symptoms are not related to disease severity. So actually, I think, again, if you don't do a lot of autoimmune liver disease, you assume that the only people who have symptoms are the people who have horribly advanced liver disease, and that isn't true. So I see people who have really very little liver disease per se, but do have lots of symptoms. And yes, you're right, it doesn't get better with transplant. And as it stands, the drugs we have do not improve fatigue, which is a massive challenge for us. And then just a few words about autoimmune hepatitis, which is one of, so UK AIH, so this is the UK PBC has been going for years, and then we thought, actually, this is quite a good idea, we should do it in autoimmune hepatitis as well. And this is my baby, because I look after UK AIH, and again, a lot of the patients who come to see me in clinic are in this. So this is essentially trying to understand what happens to people with autoimmune hepatitis in the real world. So you can do a drug trial, you can do clever stuff, but actually on the ground, what happens to patients? We have about, so we have 56 sites open across the country. It's a bit of a marathon to run. And we have about 2,000 patients at the moment. And essentially it's to see what matters to patients, what we don't do well, whether that be treatments or symptoms, looking to see what treatments we use and what happens to patients. And actually, essentially, we're trying to do better. We need to understand, actually, if you're on azathioprine, for example, do you just need more of that? Or do you need a different drug? Can I not control your disease? Or am I giving you drugs that have lots of side effects? You know, a lot of the people in the room will have at some point taken steroids, and most people will tell you that steroids give them lots of side effects, and they don't like taking steroids. And actually these diseases all have an impact on quality of life. PBC is by far the most recognised in terms of quality of life. And you probably have problems with quality of life due to both the disease itself and the treatment we give you. So it's trying to look at those things. And we're kind of try and, I mean, you guys may completely disagree with this, But when we were thinking about different groups of patients that we look after, so I do have patients who their disease is really well controlled, they have no side effects, they feel great, they come to see me every 6 months. Ideally they bring me a cake, and then I see them again in 6 months' time.
Is that a hint?
Some people choose to bring me chocolate and cake, that's fine. It doesn't affect their treatment. There are some people who I use lots of drugs, I'm quite aggressive with treatment, trying to do the best we can, but some people I just really struggle to get good control for them. And some people I can be really proud of myself because their blood tests are great and aren't I a brilliant doctor, but actually they feel rubbish because I'm giving them side effects with their drugs and that's no use to anybody. And I think actually probably that's the biggest, or the kind of biggest challenge in some ways, that we can do well kind of with the doctory stuff, but actually we're failing in terms of side effects and things. And I think each individual probably would take a different kind of balance. So I do have somebody who's on MMF, which is one of the immune suppressants, who gets really bad diarrhea with the MMF and will say, I'll take the diarrhea, thanks, because you've got my autoimmune hepatitis under control, and I would rather have my autoimmune hepatitis under control than have diarrhea. But not everybody would agree with that. So everybody's different. And as I say, people don't like steroids. If you speak to kind of large numbers of people, they really don't like steroids. What dose is okay? When ideally none would be good, but so we talked about treatment goals for PBC. I would say that here we need a range of options. Everyone's different. What fits one person? If you come to my clinic, I see, I don't know, well, I've got hundreds of patients with autoimmune hepatitis, and there are very few people who are on the same, everyone's on a different concoction of things, trying to get the right mixture. And we want better treatments, actually. Autoimmune hepatitis, there have been no treatment developments for decades. There have been no new drugs, and we are desperately trying to change that. So this is just, as I say, this is when I wrote, well, actually I only wrote these slides for you. 1900, probably nearer 2000 now, because we're reopened, so 2,000 patients in UK AIH. And actually, John mentioned we're kind of, obviously a big centre, but actually in UK AIH we have a split between, so there are 7 transplant units in this country, if you include Scotland, and UK AIH represents transplant units and non-transplant units, and I think that's important because actually a lot of people aren't looked after in a big centre. So there's about a 50-50 split in the study between centres like us, and 80% again are female, so that would be what you would expect in autoimmune hepatitis. And I want to get good disease control, I want to get your blood tests normal. Now, autoimmune hepatitis, I said I don't biopsy very much in PBC. Anybody in the room with autoimmune hepatitis will know that if you sit still for long enough, I quite like a liver biopsy because I think it gives you lots of information and it's very helpful. Ideally, I want to get you on as few drugs as possible. So I want to give you good control of your disease with as few drugs as possible, and I want to get off steroids. And obviously, I want to stop your disease getting worse over time. As I say, normal quantity and normal quality of life is what we're aiming for. So the kind of key findings from UK AIH, actually, I think autoimmune hepatitis has a reputation for being a really easy disease. As somebody who does an awful lot of it, I would disagree with that. I think it's a really challenging disease, actually, in terms of looking after people. And actually, only about 60% of people have really good disease. This isn't in Newcastle, this is nationally. The only drug with evidence in autoimmune hepatitis is azathioprine. Now, bearing in mind there's only one evidence-based drug, there are 29 different treatments being used, so for various reasons. We want to get everybody off steroids, and over half of patients are still on steroids. So that's...
Why is that, Lee?
So that is a good question. So some people, because they've got difficult to control problems. Some people, because they just don't try and take them off. I'm very aggressive at giving treatment, but I'm also quite aggressive at weaning treatment. So I will give, broadly speaking, almost everybody a go at getting off steroids, because they might not manage it, but a lot.
So what happens if we take them off and then they go back on?
Yeah, but most people, broadly speaking, I would give a trial without them. After discussion, some people want to stay on them, but most people want to come off. And actually 10% of people on steroids only if on any other treatment. And I think importantly, we talked about kind of trying to prevent advanced disease, but actually in autoimmune hepatitis, a quarter of patients have cirrhosis at the point of them being diagnosed. So presumably they've been, you know, had that problem for quite a long time, because it is quite, we talked about PBC being actually relatively easy to diagnose, autoimmune hepatitis is more
do they get the
difficult.
cirrhosis first?
So they have cirrhosis by the time they're diagnosed, so they'll have had, there will have been a period when they had their autoimmune hepatitis, but people didn't know about it, they didn't know about it, and then by the time they've...
Is that why you do the blood tests?
Yeah, exactly. But it goes to the point that I think also a difficulty with rare diseases is they're more difficult to recognise. You know, I can do your blood pressure and tell you you've got a high blood pressure, but it's not as easy as that with autoimmune, well, any of the immune system problems.
I've got a theory, everyone should go to the jungle. So in the jungle, they don't get diseases.
They don't get blood test either, so that would be a good idea.
Can you ever get rid of it, apart from a liver transplant?
Yes.
Once you've got the cirrhosis, then can you get rid of it or not?
So that's a very good question. So I can't make your cirrhosis completely go away, but if you think about a scale, and cirrhosis, the way we rate things, cirrhosis is 6 out of 6. Yeah. So if you, not you, but if somebody presents and has cirrhosis and 6 out of 6 on a liver biopsy, and I treat you very aggressively, we can take you back down that scale. Right. So I can't completely heal it, but we can shift you back into the scarring in the liver. I mean, the liver is a fantastic organ, it has a great ability to heal. So what we're trying to do is shift you back down. Because actually, patients with cirrhosis, the liver often works very well. Yeah. So, and what we want to do is kind of reduce the amount of scarring, reduce the amount of inflammation, and keep somebody's liver, even if they've got cirrhosis, working for, you know, decades potentially. Right. So people are very scared by cirrhosis, obviously. But, you know, people with cirrhosis can live for decades with liver disease and come and bring me cake. And quality of life, I will speed up, I'll stop talking, I can talk about this all day. So we talked about PBC, so it's very well recognised. PBC has got a real kind of, if you look on the LIVErNORTH or, you know, any of the kind of British Liver Trust or what have you, PBC everyone's aware of. But actually autoimmune hepatitis has an impact on quality of life for patients as well. People are more fatigued, there's more depression, people are scared about what's going to happen to them. And we kind of, and it's never really been looked at. So actually UK AIH, we have now looked at it. It's nearly 1,000 patients. This is by far the largest study that's ever been done. And we compared them with normal. I mean, who knows what normal means, but there is normal data from the UK population. And we also compared them with a group of PBC patients, because you know that PBC patients get fatigue. So we're comparing, and we took various quality of life questionnaires, a fatigue questionnaire, and anxiety, and HADS, which is a hospital anxiety and depression scale. And actually we did find that autoimmune hepatitis does have a significant impact on quality of life for patients. And actually there wasn't any difference between autoimmune hepatitis and PBC. So PBC is a disease that is recognised to cause fatigue, everybody knows about it, but actually autoimmune hepatitis is a significant problem as well. Interestingly, if I do a good job of disease control, so I get good disease control for you, your quality of life improves. So, but steroids are bad in terms of quality of life. And actually, if your disease is poorly controlled or you're on steroids, you feel generally worse, more fatigued. So those are things I need to do better. I'll go through that. And we talked about, so obeticholic acid, which is the new drug for PBC. The first new drug is the only new drug in 20 years in PBC. So it's quite a big step forwards. Autoimmune hepatitis, there is a trial ongoing. For the first time, there is a drug trial ongoing. We are open in Newcastle. I've not managed to recruit anybody yet. But it's difficult because actually, no size fits all, and PBC is a much easier disease in some ways to design a trial around. And what do we do? Do we try and look after people who are just at the first point of diagnosis, or do I go for people? So if I give you a drug and it doesn't work, do I then do a trial of a new drug? Or do I say, well, actually, the people who really need a new drug are the people who are on 20 milligrams of penicillin, and actually it's those people, we don't know. The trial that is running at the moment is people who are on standard treatment who I can't get good disease control, and we give them a different drug. And I think the other really important question in autoimmune hepatitis is, who can I stop treatment? So there are a small number of people who I can take off their drugs altogether and they will be fine. The question is who they are, and we're not very good at identifying them. So I think, you know, if you're 30 and you come to see me with autoimmune hepatitis, you need to keep your liver for 60 years, and you don't really want to be on immune suppression for 60 years. And how do I work out who I can take off and who I can't? And that still is a real challenge for us. So that's a bit of a kind of hodgepodge. This will stop tour of things. I'll stop talking now.
Excuse me, what proportion of new patients would be asymptomatic that have just been picked up accidentally on a blood test through work or something?
Yeah, I would say probably about so PBC, probably about 2/3. Yeah. Autoimmune hepatitis and PSC is less likely to be diagnosed on the basis of symptoms, but PBC about 2/3 probably just go for a blood test for another reason and get found to have abnormal blood tests and then come to see me.
Have you done the lady somebody had bowel transplant then?
So there's quite strict kind of rules, if you like, not that surprisingly. So we mentioned itch being one of them, so you don't have to have terrible liver disease, but you can have terrible itch. Basically, if you're at a point where your liver is not working well enough, so at the point where having a transplant, which is obviously a major operation, gives you a better outcome than leaving you with your own liver because your own liver isn't working very well. There's various ways. There's not a kind of time period as such. There were kind of and there's kind of markers of things that. So if people are turning yellow, for example, or if people are having bleeding problems, for example. So there are kind of things that we look out for particularly. But there is a tipping point at which you would be better with a new liver than your own.
If a drug's not licensed for a specific thing, how can you actually prescribe it?
So essentially, as an expert, I can say that the clinical evidence for this and for this patient, this is a good drug to give to them. So I can give off-license medication. You can't just kind of give it out kind of willy-nilly, but yes, you can say as a kind of expert medical opinion that I feel it's appropriate.
So I can't understand how you found out that it worked.
Yeah, so that's a really good question. Presumably somebody just gave some to people and noticed that their blood tests got better. It must have been, I'm not... That is a really good question.
Company?
No, because fibrates, so the drug company who make obeticholic acid have now bought fibrates. Right. Because they're not stupid. But it wasn't a drug company thing at all. So fibrates are as cheap as chips. They're like 90 quid for a month or something. So there's no money in it for the drugs company at all. The old drugs company, because they're not on patent, so they're cheap as chips.
So they don't test them first.
So fibrates, which is what John's alluding to, fibrates are licensed as a cholesterol drug. Right. So they are tested in other settings. Right. So they're licensed for safety for other settings, but then we use them in PBC.
How do they test it to make sure they're okay?
So for drugs to get licensed, they have to go through trials and trials and trials of safety.
Do they use it on animals, or do they use it in people, or?
So broadly speaking, for a drug to get licensed, they have to go through various rounds. So a lot of drugs, if we're honest, are tested on animals in the very early stages, but then people in the room who've been through drug trials, so they do kind of rounds of drug trials for safety.
Can I just ask, I know a couple of people, I know you haven't touched on PSC.
Only in my modelling obsession, only my maps.
Okay. It's just I've come across a couple of people who have either themselves or who have relatives who have been, they can't get the diagnosis